So moving on to our next topic, very important one, post-herpetic neuralgia. I would like to invite Professor Meghdad Ansari. Sir, well, he doesn't require any formal introduction, but to complete the quorum, he is Professor of Pain Medicine at Al-Azhar University, President and Editor-in-Chief SRAPM, former Council Member IASP, Council Member APS, Secretary General AMUP. Sir, it's an honor to chair a session on for your lecture.
I'm going to present this topic about post-herpetic neuralgia. I wonder if it is common here or not so common, but in the Western world, in Britain and on the white race people, it's more common than in, we are lucky that with some dark skin we haven't such a prevalent problem. Actually, the post-herpetic neuralgia is one of the worst conditions on pain management. So I kept silent like Sphinx for so many years. He's the guard of the pyramids. And this statue for a long time silent, but now it is time to speak to you, and I will speak in behalf of him. Enter. Well, I would like to make it as an interactive one and to have clinical case, which is typical case and history of patients with post-herpetic neuralgia. You have a male patient, old one with diabetes and heavy smoker, COPD. The sequence will be have lung cancer, receiving chemotherapy, and he suddenly got pain in left side along the fifth, sixth, and seventh intercostal nerves. So the possible diagnosis will be usually misdiagnosed as maybe myositis, just because he is coughing all the time, or it is coronary ischemia because he's an old man, or left pleurisy, complications of COPD or lack of immunity, coughing all the time, it may be fracture ribs spontaneously after emphysema of the chest, but nobody thinks about the pre-eruptive stage or the prodroma of acute herpes zoster syndrome. But after 4 days, the things comes, I think you can see the red letters or not, I don't know. Now, we have to ask the second question for us, or for myself. When pain after herpes zoster should be called the post-herpetic neuralgia, I mean it is a chronic neuropathic pain. It is classic after 3 months after the acute herpes zoster infection. We can call it post-herpetic neuralgia. But is acute pain in herpes zoster predicting any outcome of post-herpetic neuralgia? In normal patients, no relation. Sometimes you have severe post-herpetic neuralgia and it's relieved spontaneously. Sometimes you have no vesicles whatsoever, which is very rare conditions called herpes sans vésique par français. It means herpes zoster without vesicles, but you have pain just along the distributions on the intercostal nerve. But in all the ages, the story is completely different. Pain starting before the skin vesicles and severe pain. Usually it is hemorrhagic skin lesion and deep into the skin with hemorrhagic patches and to great extent out of the trunk. And in this condition, you can predict that pain will be more severe. Is it good to start acute pain management and to prevent it before it happens? Yes. Early management is a secret of success of post-herpetic neuralgia and to prevent it. So lower incidence of infection if you have good diagnosis, less incidence of post-herpetic neuralgia, and the less duration. So if you pick it up early without being established, you can do a lot. Now, to sum it up, post-herpetic neuralgia equals low immunity, like HIV. The same, they are cousins. So low immunity due to old age or diabetes or chemotherapy, radiotherapy, cancer, cachexia, whatever it is. And it is very prevalent in Africa due to the acquired deficiency syndrome of AIDS and the malnutrition. And to my mind, the malnutrition is more important than AIDS. Of course, in Caucasian race, past history of chickenpox is a key factor to have in the adulthood or in the old age some sort of activation of post-herpetic neuralgia. Now, I have been in Uganda in hospice for treating terminal cancer and in treatment of AIDS, and you can see such a poor child. He is born from a man and a woman with AIDS, and he just crippled the child like this. Very rare conditions of post-herpetic neuralgia to be bilateral. Usually it is unilateral, but I have this record from the pain clinic at Azhar University. An old patient came to the clinic with such bilateral herpes zoster, and it's worse to, I have to take a picture for this man. Here he's painting his body with gentian violet, and here is some patches of discoloration, and now you can see it's more and more hemorrhagic and deep, and eating all the dermis or the epidermis, so eating the skin maybe to the superficial fascia of the patient. And now it starts to heal with this café au lait discoloration, and I'm going to discuss it later on why it is café au lait, because it is something very interesting to say. But what are the predisposing factors for such conditions? Actually, if you have, for clinical sense, we can classify it according to age, but no limitations. You can find any overlap between this, but just for expectation, if from newborn to 18 years old, the possibility of AIDS born from the mother or father, or leukemia, Hodgkin, and so on. But from 20 to 40, steroid therapy, AIDS, diabetes, and so on. And in cases of old age, you start by malignancy. So it is coming like in this manner, but sometimes there is no rules. As regards the sex, no difference. But as I said, the people with dark skin like African, Indians, and Latin Americans are more resistant to the Caucasian or Caucasian fair white race. And there is certain explanation. I hope it will be satisfactory. Actually, sometimes social factors like stress for examination, stress for a widow or a man lost his wife, or he lost one of his favorite offsprings. It will be, I'm sorry, dose escalation until you reach the full dose. Paracetamol or acetaminophen, weak opioids, especially tramadol is good because it has serotonergic and noradrenergic action. They are very good in such a problem. And then codeine and steroid opioids, strong opioids, only if it is associated with cancer, because if you start opioids in a patient with non-cancer, he may stuck with strong opioids, and it will be a great problem for yourself. Then co-analgesic like gabapentins and the pregabalins, but some, I think they are expensive to the moment in Egypt. They don't know the situation. Carbamazepine is good and cheap, but it causes bone marrow depression, skin eruptions, and the enzyme induction. So you give an opium, or you give opioid, or you give morphine or tramadol, and then carbamazepine will destroy them. Sodium valproate is okay, but liver damage is expected. And mexiletine, which is a local anesthetic, but it is systemically used. And we have such eruption of the patient with carbamazepine, because sometimes we cannot afford gabapentin or pregabalin. Now the antidepressant, non-specific, very cheap amitriptyline is good, but you have to take care if the patient is old age with urinary retention, glaucoma, tachycardia, and all the side effects. Now the Western world start to have mexiletine, still very expensive, but sometimes we can use it if the patient contraindicated for such conditions. And it's better to use non-specific antidepressant rather than the specific one, because the non-specific is more potent in such conditions. Now, that's my aim, is to give such poor patients. And if you look at this man, if you don't know he's Egyptian, he is one of your population here, very easy. They are doing the same like
So,
in Egypt.
I'm
and
afraid to tell,
fine,
time
two
is
slides.
time is over. Yeah.
Yes, sir. Intervention in the form of neuroaxial blocks, sympathetic trunk blocks, are to be adopted. Both techniques will relieve pain, enhance instance of healing, and prevent the development. So in acute stage, not in chronic stage, you can do interventions. Curative in the form of analgesics, okay. Topical local anesthetics, expensive. EMLA cream may be good. Lidocaine also expensive. Lidocaine gel is okay, very cheap. And capsaicin, that's the last one. Interventions, epidural analgesia with catheter implantation, 5 ml bupivacaine and morphine and clonidine. Epidural catheters for needs some experience, and radiofrequency, whatever it is you can do. Had all the analgesics present in pain clinic in Egypt, and this is if you would like to explain or to stop. What's your, I'm sorry? Go on. Now, it's a technique to put a catheter, normal catheter, if you have no pump, if you have no such, so many facilities, you can put a normal catheter, and you have to do tunneling with 2 knots to fix it under the skin, not the catheter to be pulled out. And then whenever you do a knot, you have to do testing of the saline until you are sure that the knot is strong enough to fix the catheter and loose enough not to pull the catheter out. And this is very delicate technique. Actually, after that, we have very short tunnel, and you can use 1 or 2 filters. This will act for about months or 2 months with careful administration. If you have more money, you can do a port, or you can do automatic electronic device. It works also, is less expensive. And you have just pressurized pump or electronic pump, but also expensive, not, and radio frequency or spinal cord stimulation. So my message is, for post-herpetic neuralgia, either you have evidence-based medicine or you have no evidence-based medicine. But all the methods possible to control or to prevent the post-herpetic neuralgia should be adopted. Otherwise, if the condition is established, it is very difficult to get rid of it. So post-herpetic neuralgia is a resistant pain syndrome related to low immunity. It should be kept in mind from pediatrics to geriatrics. Aggressive treatment should be started in acute stage to abort post-herpetic neuralgia. Every method for pain management should be done to stop the pain of post-herpetic neuralgia. Thank you.
Well, thank you, Dr. Ansari, for this elaborative presentation on this important topic.
Thank you.
Well, and now the house is open for questions. Any queries from the audience? Yeah, sure.
What about the paravertebral? Is there a role of paravertebral blocks? Paravertebral blocks in the post-herpetic neurologic pain?
As I said, you can adopt any technique. If it works and you can do paravertebral block, go ahead. There is no nothing contraindicated. But neuroaxial blocks will be more beneficial to do a sympathetic block over and also some sort of pain block. So because in post-herpetic neuralgia I have both. But if you can do paravertebral block, go ahead. As I said, any method you have or you can control it and do it well, do it. Don't stop. Because in some evidence-based medicine said that this technique it will work, this technique it wouldn't work. But we can't gamble. It's a sort of gambling. If I'm not going to attack this condition aggressively, I have it. Because nobody knows to the moment why it is resident. And why it is present? Because the nerves are completely burned or damaged. Okay?
In UK, Versatis, which is lignocaine 5% plaster, is indicated, I mean, it's licensed for use in PHN. My question is specifically to chronic pain consultants from India. Is it available in India yet or no?
I'm sorry?
Yeah, 5% adhesive plaster. No.
Hypertonic saline. I don't get you well.
Sorry, lignocaine 5% plaster. Is
patch or
patch.
No, it's
Patch,
not,
medicated plaster.
I said it is expensive, so it is not present except in maybe in the United States or in England.
It is yeah. It
But
is
it is-
licensed for use.
I'm sorry?
It is licensed for use in England.
Yes.
And we use it quite often. The advantage is even if you buy one patch, you can trim it to the size of your most painful area. So it's not like one patch one day. You can trim it and use it
Yes.
multiple times. So even though it is expensive, it may be that if you use one patch 4-5 days, it may
Yes,
work.
maybe in England as a NHS you don't care much about how much it expends.
No,
it
we
costs.
do care.
They do,
We do care.
but not you, but the administration. But if you have a patient, poor patient, and coming and this drug is not present in the hospital, you have to order it for him. But how he can buy? He has to sell his one of the furniture at the home to buy the patch. So I'm with great respect to what's going in England, but here I am in India and I am in Egypt. We have the same problems.
How expensive is it in Egypt?
I'm sorry.
How expensive is it in Egypt?
Well, it is expensive to the degree it is not available whatsoever.
Oh, it's
But
not
yes,
available.
but some, if I have VIP people like everywhere, and I have patients like Ambassador, or a patient has 3 or 4 Mercedes coming at his villa, so I ask him, you can buy it? He says, yes, I can ask anyone coming, and I order it by emails. It will come for him into 24 hours. But for the majority of people, they cannot afford it.
See, Nick, one of the reasons that these patches are available is because seeing a doctor there is more expensive than actually prescribing the medication. Versatis patch for a 4-week supply, it costs in the region of about £125. That will be about 12,000 Indian rupees. I've used Qutenza patch as well. It is approved by NICE and I've got very good results with that.
Yes.
But the problem is, again, the expense. A single application of the patch, just the patch, costs in the region of £550.
How
That
much?
is
How
about
much?
50,000 rupees.
How
But
much?
A single £550.
550 pounds.
Yeah. That's the Qutenza patch, the 8% capsaicin patch.
Okay.
I've had fantastic results with that. A
Yes.
single application can give you between 4 to 6 months worth of pain relief from post-herpetic neuralgia.
Yes.
But
Can you multiply this by 20 in Egyptian currency?
that would be about 100,000.
Yes.
Yeah.
So it's better to have an apartment rather than to have a patch. With 100 Egyptian pounds.
The patient has to be admitted as a day case. You need about 4 to 6 hours with the patient. The patient, EMLA has to be applied. You have to prepare the part for about 45 minutes. Then you rub the EMLA off. Then you put the patient a patch on. And the patch has to be applied for 90 minutes, 60 to 90 minutes. It's usually 90 minutes.
Yes, but EMLA is just a tube like this, and it costs about 10 Egyptian pounds, which is equal to 40 or 50 rupee. And some patients cannot afford it. They haven't 40 per rupee to put it, because this tube will finish in 24 hours.
We don't have lidocaine patches in India, but we have seen a few cases where we applied EMLA in these patients of post-herpetic neuralgia. And the results were encouraging, and we have sent this for publication as well. So,
Yes. Any other questions?
Well, last comment.
We have now pregabalin with the 2% lignocaine. That is also some cases practically useful. I don't have any literature evidences for that. Some of the resistant cases I prescribe that somewhat better managed with 2% lignocaine with the pregabalin patches also. It's available. That's a very cheaper.
Yes, the gentlemen are in the back, please. Yeah, use the mic, please, because
I just wanted to say, from experience, we must have realized none of these treatments are guaranteed.
yes,
And there is a one simple treatment you can give if you see a patient from day one, 25 milligram or 10 milligram of amitriptyline for 3 months.
yes.
It has shown to reduce incidence and severity of PHN in these patients. I don't know how many of these patients are seen from beginning. In UK, we don't see them because GPs see them. But here, I think if you can see them from beginning, it's worth giving them for 3 months. Very cheap medication, amitriptyline 10, 25 milligram. It does help in long term.
Yes, to tell you a secret, but
You mean from beginning, that means from
Can I
acute-
reply,
acute-
please?
Acute herpes?
Can I reply?
Yeah, sure.
Yes. I have experience about 35 years in pain clinics, and I spent 20 years asking the dermatology department to transfer the cases of acute herpes zoster, but they are refusing. Okay, and then after some time they start to have that we have something to do with post-herpetic neuralgia. So I have a protocol with them that I'm not going to treat the acute condition, but now I am going to prevent. So the treatment will be hand in hand. Do whatever you like with the patient as regards ointment and acyclovir and so on. And I'm going to start by triptizol or amitriptyline or pregabalin or whatever the pharmacology we have here. And I let them to treat the patients. So that's the only solution, is to convince others that we are not going to pick up cases from them, because I think you have private practice here and everybody is aware about his pocket. So so long that he is assured that I'm not going to pick up his patients, but I'm going to help. So I am courageous enough to go there and to give them lectures about the pharmacology and about the use of these anti-epileptics and amitriptyline. But actually they said, no, we have no mind for such complicated pharmacology and when to use and when to use, do it. So we got confidence, but after 20 years.
Thank you, sir.
Now I have the protocol and I have a lot of cases.
Thank you, sir, for your wonderful lecture. I would like to invite Dr. Sarita Singh, who is an additional professor in Department of Anesthesiology, KGMU, Lucknow. She has done her PDCC from BHU, Varanasi. Her prime area of interest is low back pain management. I would also like to invite Dr. Sanjay Kumar, Associate Professor in Department of Anesthesiology, SGBGI, Lucknow. Madam, sir, kindly take over the session.
Thank you. I would like to invite Dr. Surya Kumar Dubey. Currently, he is working as assistant professor in the AIMS, Delhi. He has published 65 publications in various journals, in editorial board of 2 journals, and he received, he is reviewer of 6 journals. Please start.
Thank you, madam, for the introduction. Anyway, I had to write something for a brief introduction for myself. That's why I have written. But after seeing the lectures and meeting the experts in this field, I'm very much honored to be a part of this event, and I'm speaking in front of this August gathering. And good afternoon, esteemed senior faculty members, and thank you, the organizing team of 6th ICPM, for providing me this opportunity to speak here. And basically, I'll be discussing something about current evidence for percutaneous interventions in trigeminal neuralgia. This is an outline of my presentation. There will be a few slides on background and treatment options, what is available for trigeminal neuralgia, what are the types of percutaneous procedures that are available, what is the recent concept, and finally I will summarize and I will conclude. As per the traditional definition by International Association of Study of Pain, trigeminal neuralgia is a sudden, unilateral, brief, stabbing, recurrent pain in the distribution of one or more branches of fifth cranial nerve. Pain occurs in paroxysms that can last for a few seconds to several minutes. The frequency of paroxysm ranges from few hundred attacks a day. But as per the recent definition by International Headache Society, the clinical criteria for trigeminal neuralgia diagnosis is at least 3 attacks of unilateral facial pain occur fulfilling these criteria, like occurring in 1 or more division of trigeminal nerve with no radiation beyond the trigeminal territory, and pain with at least 3 of the 4 characteristics, like recurring in paroxysmal attacks lasting for a fraction of seconds to 2 minutes, not more than that, severe in intensity, electric shock like shooting, stabbing, or sharp in quality, and it is precipitated by innocuous stimuli to the affected side of the face. Now, this is the slide depicting what are the usual progression in case of a trigeminal neuralgia. Initially, there will be periods of exacerbation and remission, and eventually the remission period that vanishes, and what we get is a exacerbation and increased intensity of pain. And this condition may impair the activity of the daily living and can lead to depression and anxiety as well. So it's worth discussing what are the treatment modalities available for trigeminal neuralgia. To summarize, there can be pharmacological treatment like carbamazepine is an established effective drug. Oxcarbazepine may be an alternative. Baclofen, lamotrigine, and pemozide are second-line drugs. And coming to the non-pharmacological measures for trigeminal neuralgia refractory to medical therapy, early surgical therapy may be considered, which includes percutaneous procedures on gastrin ganglions, gamma knife, and microvascular decompression. And as of now, microvascular decompression may be considered over other techniques to provide longest duration of freedom. But in our domain, we don't do microvascular decompression, so primarily we'll be focusing on the methods that we do normally. The rational approach would be the patient who cannot reach the effective dose of carbamazepine or oxcarbazepine due to contraindication or adverse events should try second-line drugs. And the patient who do reach the effective dose of carbamazepine or oxcarbazepine, but do not experience enough pain relief, become the candidates for surgical interventions, which includes peripheral procedures like peripheral neurectomy, cryotherapy or peripheral injection. This percutaneous procedures which include percutaneous balloon compression, radiofrequency ablation, and glycerol rhizotomy. Open procedure like MVD and partial sensory rhizotomy, and stereotactic procedures like gamma knife radiotherapy. In our centers, we have all the open procedures. We do microvascular decompression and gamma knife therapy as well. And in our pain clinic, we basically do these percutaneous procedures. Now, the percutaneous procedures on gastrin ganglion, which are also called percutaneous rhizotomies, involve penetration of foramen ovale with a cannula, then controlled lesion of the trigeminal ganglion or root by various means that can be thermal, which is called radiofrequency thermocoagulation, that can be chemical by glycerol, what we call glycerol rhizotomy, or it can be mechanical by a balloon, what we call a percutaneous balloon compression. So, what should be the approach in this patient? Because it's not about the literature what they say, but sometimes the patient characteristics or expertise in the field, or the person who is doing his own experience in doing a particular procedure, and of course your logistics and your support system what you have at your centers, they also may decide what is the procedure to be adopted in these patients. So for the sake of presentation, I have taken help of this few studies, and I have categorized these different interventions to gather the recent evidences. And let me be very frank and clear, till date there has been no randomized control trial that compared a particular percutaneous procedure versus a placebo, obviously because of ethical concerns. And I'm sure in the coming near future, there is not going to come any randomized control trial which compares a particular technique to other. What we get is reviews and what you are experienced with case series or cohorts. I will try to summarize this 3 techniques as per the patient characteristics. What is the success rate of the procedure, what are the complications, and what is the cost effectiveness of the procedures. Coming to the patient characteristics, for patients with acute pain, percutaneous procedures are usually better suited than open procedures, but patients with cardiovascular comorbidities are not good candidates for percutaneous balloon compression because of high incidence of intraoperative arrhythmias and hypotensions. And because of low risk of trigeminal motor dysfunction, glycerol rhizotomy is particularly advantageous for patients with trigeminal motor weakness or temporomandibular joint dysfunction. Now, this is a table that I have chosen from one of the study, one of the references what I mentioned, and the maximum the references which are shared in this table are usually the most often cited references in this context. What we can see in this table that comparatively more patients are opted for radiofrequency thermocoagulation, maybe because the initial pain relief and the subsequent follow-up pain relief is comparatively more with radiofrequency thermocoagulation, but simultaneously percutaneous balloon compressions are also effective with a comparable post-procedure pain relief, but glycerol rhizotomies are less favored because of their lesser initial pain relief and there are chances of frequent recurrence after the procedures. So as per the success rate, radiofrequency ablations procedures are successful, followed by PBCs and glycerol rhizotomies. And now coming to the complications, what I need to stress upon that all percutaneous procedures have similar rate of dysesthesia, because the percentage, some studies they say that 7 to 10%, some 10 to 12%, but eventually if you grossly say all percutaneous procedures are almost similar rate of dysesthesia, but radiofrequency thermocoagulations have highest rate of facial hyposthesia and corneal hyposthesia, and simultaneously, in spite of, in addition to lesser initial pain relief and higher recurrence, glycerol rhizotomies are known to be associated with certain troublesome complications like meningitis and herpes labialis, and percutaneous balloon compressions can cause bradycardia and hypotension, I have also mentioned, but they have highest rate of trigeminal motor dysfunction as well, and with lowest rate of corneal anesthesia and keratitis. Now coming to the cost effectiveness, to let me be very frank, there are few studies in the literature that have analyzed the cost effectiveness of these procedures, but the percutaneous procedures are more cost effective than stereotactic radiosurgery or microvascular decompression, and among the percutaneous procedures, percutaneous balloon compression is comparatively less cost effective because of its early recurrence. Again, they have not compared this PBC with glycerol rhizolysis, so I cannot say whether it is how it is validated, but this is how that is mentioned in most of the studies, that it is comparatively not cost effective. And percutaneous destructive neurosurgical techniques can achieve immediate pain relief similar to microvascular decompression. Therefore, they can be considered for acute pain in case of trigeminal neuralgia. Percutaneous destructive neurosurgical techniques can be repeated for trigeminal neuralgia pain recurrence, but the damage to the nerve is cumulative. That is, each retreatment is therefore associated with a cumulative higher risk of trigeminal deafferentiation, and deafferentiation pain in case of trigeminal neuralgia is very troublesome to manage. And as per the evidence, latest evidence, RFTs, that is radiofrequency thermocoagulation, may offer higher rate of complete pain relief, but it is associated with highest rate of complications. And conventional radiotherapy thermocoagulation is preferred over pulse radiotherapy. It is based on the small RCTs. They have compared between this conventional and pulse radiotherapy, and they have mentioned that conventional radiofrequency thermocoagulation is the method of choice. Now, this I want to share with you. I was searching the literature, and this study was like recently being quoted, that percutaneous trigeminal ganglion radiofrequency thermocoagulation alleviates anxiety and depression disorders in patients with classical trigeminal neuralgia. I was wondering what is so special about then percutaneous radiofrequency thermocoagulation and depression and anxiety. But when I studied the details of the study, they have mentioned that all the patients, they have received radiofrequency thermocoagulation because it's what they thought is the effective pain relieving method, and what they postulated is like the effective pain relief by this procedure that has caused decrease in depression and anxiety alleviation, rather than any procedural advantage that the particular procedure is causing that. So what they wanted to tell that they have, because radiofrequency ablation is a common procedure that is known to cause highest pain relief, they have used it, and they have found out that with RFTs the anxiety and depression are less. So, coming to the conclusion of this topic, percutaneous interventions are needed for trigeminal neuralgia refractory to medical therapy. No RCTs till date that have demonstrated the superiority of a particular technique over other. All percutaneous procedures had similar rate of dysesthesia. Glycerol rhizotomy had the highest rate of pain recurrence, so these are less preferred. Balloon compression had the highest rate of trigeminal motor dysfunction and the lowest rate of corneal anesthesia and keratitis. And radiofrequency rhizotomy had the highest rate of initial pain relief and the lowest rate of pain recurrence, and it is often the initial procedure of choice if the patient is to undergo any non-pharmacological treatment in case of trigeminal neuralgia.
One is that it is the safest thing to do.
Yes, sir.
There are hardly any complications.
Yes, sir.
The only flip side of this procedure is that the onset of action is about 2 to 3 months away from the day of procedure.
Yes.
Because it takes gamma rays some time
Yes.
to destroy that ganglia. Otherwise, any patient, be it person with CAD, be it person hypertensive, diabetic, all kind of things, and most of these patients, as Dr. Mohan has said, they are old patients. They
Yes, sir.
have their own comorbidities. So this procedure is very, very eminently suitable to them. Younger patients fine. Older patients also, I think this is one procedure which is the procedure to do, and it's not all that uncommon. Most of, I think in Delhi there are at least 6-7 centers. Apart from the government sector where Dr. Mohan works, there are private sectors also. I think 6 centers are there in Delhi itself. And I'm sure there will be plenty in Mumbai also, which I'm not aware, and other metro hospitals. So this procedure is available. It comes at a cost, yes. No complications, by and large, the safest procedure, and any patient can be, fit for it.
I would like to invite Dr. Virendra Mohan. Sir is a professor at AIIMS.
Thank you.
And he is working in anesthesia and pain. And he has more than 50 publications to his credit. So, welcome Dr. Virendra Mohan. Sir will be speaking on the topic current evidence for the percutaneous intradiscal interventions.
And good afternoon to my distinguished seniors and all my colleagues. Before I begin my presentation, I would like to thank the organizers, especially Dr. Anil Agarwal, Dr. Sujit Gautam, and Dr. Gurgaonkar for inviting me to this conference. I will be speaking on current evidence of intradiscal procedures. Before I proceed, let me talk a little bit of back pain. Back pain, as you know, all know, it's a very major health problem. Apart from its major health problems, it also have associated issues. And in majority of the patient, maybe around 25 to 36% of the patient, intervertebral disc is a major pain generator in back pain patients. Okay. And degenerative change is supposed to be pathological cause of back pain in these patients. What happens with aging or degeneration, what happens is that annulus become very weak, that gives way. There may be annular tear, circumferential tear, so that there will be leakage of nuclear material, and that will produce an inflammatory cascade, and the patient can experience pain. And sometimes with herniation or bulging of disc, that may compress the neural structure, and that may also compound with the pain effect. And with over time, as you all know that only the outer 1/3 of the annulus is innervated nociceptors. With degeneration, what happens that ingrowth, there will be ingrowth of the nociceptors, and with even if normal loading, like standing, sitting, the patient may experience pain, and that may become worsened with over time. As you all know, the conventional management of back pain is like physiotherapy or analgesics, and in some patients, with those patients require surgery, or some patient where that refractory to conventional management, patient can opt for surgical intervention. There is a majority of patients we are not fit for surgery or not refractory to the conventional management. In those patients, you can give an option of minimal invasive percutaneous intervention procedures. And basically these procedures, there are only two goals. One is ablation of intradiscal nociceptors, or in herniation or bulging patient where there is some compression of neural tissue, there is removal of herniated material. because that will decrease the volume and will decrease the interdiscal pressure, and subsequently will have patient pain relief. Coming to various interdiscal procedures, it can be divided into two groups majority. One is annuloplasty, that is basically annuloplasty of annular fibrosis, and there will be percutaneous discompression, that you take out some part of the nucleus material, or by physical means, or by laser, or by radiation ablation. The various annuloplasty procedures like interdiscal electrosurgery, one of the initial procedure that was practiced, IDET, another is endotronal posterior annuloplasty and bicoplasty, and various percutaneous discompression like manual percutaneous lumbar discectomy, that is automated percutaneous lumbar discectomy, mechanical discompression like it's a miniature of PLD only, decompressor, or laser discectomy, or one of the, this is a coagulation is one of the newest technique we are using. Now coming to indication basically that if the patient have persistent back pain or leg pain more than 6 months, that especially in annuloplasty, if the history is consistent with discogenic pain, or the patient is having 1 or 3 disc involvement, or especially in terms of this discogenic pain, if the patient have positive protracted discography, and if the CT shows posterior annular disruption or radial tear or concentric tear, those patients can be included for annuloplasty. Apart from this, the decompression, in decompression, those patients can also be, we have that bulge or some herniation, or that patient have pain score of more than 6 or 7, or there is a less than 5 millimeter of herniation. Those patients can be selected for APLD procedures. As per this, these are contraindications for like in those patients who have serious disposition, one should not do. Excluded or secreted nucleus pulposus should be avoided. Previous lumbar back surgery. And in those patients who are already intervened interdiscal IDET procedure, one should not do. And significant nerve root impingement that comprising chronic lower extremity diplomacy should be excluded. Apart from that, grade 2 spondylolisthesis, then pregnancy, and if the patient having some psychological impairment, those patients should be excluded from this procedure. Now coming to one of the earliest procedure, that is interdiscal thermal electrothermal therapy. Basically, this employs a navigable interdiscal catheter that is guided into the outer annulus through the tear. This spine catheter is available, and after insertion, the catheter position is placed along the internal margin of the posterior annulus. And this catheter have a distal portion that is 5 to 15 centimeter, and this is heated for 16 minutes at 90 degrees centigrade, and this cause a temperature above 60 degrees posterior, causing denervation and also cartilage granulations. The possible mechanism that extensive risk can cause that heating or thermal coagulation can collagen degradation, that will cause a decreased quantity of collagen, and there is chances of fibril shrinkage and chondrocyte damage. And effectively, this produces pain by changing its disc biomechanics, causing annular contraction. It will seal the annular tear. It will denervate the nociceptors. It will decrease the interdiscal pressure. Once these happen, they will always decrease, and there is chances of shrinkage of annulus, and the patient will have prolonged pain relief. This is how we position the catheter. In all the, let me tell you that in all the percutaneous discal intervention technique, the same technique is used. You approach the disc by posterolateral approach. Once that needle, this catheter is induced, placed in the posterior annulus, and heating is done. The initial results show around 50 to 70% having severe pain relief. And in fact, there is a large RCT in in those, these are 40% patients have more than 50% pain relief. And there is a review by Appleby that shows sufficient evidence of effectiveness safety of IDET. But there is another review that Freeman et al. That survey that very little effect on pain management and functional improvement of the patient. These are few recently available articles. This is a RCT. This is a review by that compared the low back, the spinal fusion and intercalated therapy in low back patient. They found that only 2 RCTs of IDET, and in IDET patient, that patient have decrease in pain severity by 50% and improved back function 42% and improved quality of life in 40-60%. And they said that IDET appears to offer a sufficient symptom amelioration, and they advise that it's a very good procedure in back pain patient. Similarly, there is a study that is IDET in lumbar discogenic pain. There is a 24 month follow-up, and mean pain score improved from 6 to 8 to 3, and most of the patients have improved function, and this claim that have a durable clinical improvement in selected patient. Similarly, there is one study by this is a systemic review. They also that in this review also they have only 2 RCTs. Most of the observational studies, and they claim that so far functionally significant relief in 50% patient, but minimum evidence of RF angioplasty. They have compared, they have searched the literature for this also. They claim that they may have radiofrequency angioplasty. This is a study that for 24 months result follow-up, that 50 patients included, follow-up 24 months, back pain relief by 68% patient, and functional improvement in around 66% of the patient, and overall global clearance achieved was 78%. They also claim it's a very good modality, and one can go for this. In fact, most of the reviews that they claim that most of this modality can be applied, and the patients have around 60 to 80% pain relief, and functional status also improved 60 to 80%. But the limitation of the reviews was that there were that time only 2 RCD was there. Most of them were original studies. Another angioplastic procedure we do is bicoplasty. As the name suggests, bi means 2 and acus means needle. They insert the 2 needles. It's a transdiscal system is available, and the 2 needles are placed in the same disc, and concentrating the RF current is passed between 2 ends of probes. And advantage of IDET is that IDET use only heat. This use RF. So heat production compared to IDET is less, and relatively even heating occur over a large area. And after confirming the proper position that RF generator is used, 50 degree RF 78 minutes, and for another 8 minutes for final heating. And tissue temperature, they claim they never rise above the 50%, 50 degrees centigrade. And in study that significantly occurred back in 2 pilot studies, a maximum follow was 12 months. And in another study in which they included only 8 patients, they found that 50% pain relief and satisfaction level was also 50% at 3 months. In one of the initial studies by Kapoor et al., that he studied around 15 patients and found the median VAS score was decreased from 7 to 4 at 1, 3, 6, and 12 months. And he says it's a simple procedure, very simple to plate these electrodes, and no need to thread a long heating catheter, unlike I did. This is a 6-month study that transdiscal biochemistry patient discogenic pain, and 15 patients included, 57% of 6 month improvement 6 months, and 50% of pain relief, and overall satisfaction was 78% in terms of functional status.
Excuse
where
me,
the
5 minutes or more, sir.
Aspirated material is, and actual time is around 10 minutes, and the goal is to remove 1 to 5 gram of nucleus. These are the. Another is a hydrodiscectomy spine jet. Rather than using mechanical power, this uses the water power to dissect the nucleus and subsequently suck the nucleus. These are the few studies they claim that in all the studies they found that that pain relief in 60 to 70%, and the functional status change is around 50 to 70%. Another, this is a new technique, that is coablation technique. It's used radiofrequency, combined disc removal and coagulation to contain herniated disc. In this, a band is used to remove and withdraw and aspirate the disc material, and it's repeated around 6 to 7 times. And it's a non-heat driven process. Basically, what happens that with the RFSL wet conducting medium to generate highly focused plasma field at the tip of electrode, that causes the dissolve of tissue and at low temperature, and basically you have volumetric decrease in the nucleus pulposus, and this material is converted to gases, and that is leaked out from the needle. And while you taking out the probe, it also coagulates the channel, so that you have a. This is a few picture of annuloplasty.
This is a study that shows in the first 1 year follow-up. They said that it's a case series. They include around 83 patients. And at 12 months, there is a significant reduction in the VAS score. And it says the claim it's a safe and effective treatment option for this type of patient. Similarly, there is one observation study. They include around 42%. And they also claim it's a good outcome and shown satisfactory results. There is another study that 50 patients was decreased from 8.2 to 1.0. That's quite significant. And functional status score also decreased from 62 to 9.1 a year. There is another RCT that shows 64 patients, and it also shows very improved results. Now, what is the complication of these procedures? Most of these interventions are with very minimal tissue damage, have very short recovery time, low infection rate, but complications do occur, like if we are using catheter, there will be breakage of catheter, nerve root injury, because of heat also, because of intervention also, there will be chances of disc herniation from you have put the catheter or needle, and some patient may have radicular pain because of herniation, and though chance of discitis is always there, but incidence is very low, 0.2 to 0.7%. Thank you. Basically, these intervention procedures, they are very soft in selected group patient. You can't apply all these groups in every type of back pain or radicular pain. Like in angioplasty, it's very good in discogenic pain. And decompression therapy is very good in those patients who have minimal herniation associated with back pain and leg pain. Like if herniation is less than 5 millimeter, you can opt for rather than going for open surgery.
Thank you, sir. The next speaker is Dr. Yahya Kamal. He is consultant in pain and anesthesia from University Hospital of Leicester. And his interest is in cancer pain, acute pain, and abdominal pain.
Malignant pancreatic pain has been covered in various ways. First by opioids, my colleague Sanjay's lecture about opioids, and by the blocks. But if you want us to touch on anything related to pancreatic cancer, we can also touch on that. Is that okay? So, first of all, definitions. As I said, we've just started this pancreatic pain MDT, and part of the importance is one of the questions we'll ask ourselves, whom are we going to review and why are we reviewing these patients? So basically, we've started a referral system, okay, whereby the doctors in the hospital and eventually the GPs are referring to us patients with pancreatitis and pancreatitis exclusively. And the aim, as we've mentioned, as everything in the world is driven by finances, sadly, is to minimize hospital stay and hospital admissions with episodes of acute on top of chronic pancreatitis, particularly the chronic ones. So definitions are always important. So acute pancreatitis, as you probably know, it's by definition is an acute condition with abdominal pain, and perhaps when you will find usually raised enzymes. If it carries on for a bit longer, you're going to have continuous inflammatory changes with loss of exocrine and endocrine functions, so the proteolytic and the digestive enzymes, and eventually hormones such as the most famous insulin. Some figures, I'm not sure how these figures, these are the figures that relate mostly to the UK with an annual incidence of about 1 in 100,000 and prevalence of 3 in 100,000. With males to females 4 to 1 and onset about 4 years. Now these figures are published from this paper, but these figures are actually, they're about 2 or 3 years back, and it's inaccurate now. The figures are on the rise, and interestingly, talking of equality, the rise in the rates of female patients suffering with chronic pancreatitis is increasing because of increased alcohol intake and smoking. Okay. Obviously, as you probably are aware of the pathology, it's progressive destruction, pain, lasting for a lifetime, and symptom-free periods are not synonymous with cured. You see, I like to always think of pain in chronic pancreatitis as an experiential experience. I see lots of pain patients, some of them, of course, the bread and butter of every pain clinic, back pain. And despite the fact that many of these patients have a strong history of smoking and drinking, many of them are very, I'm telling you about my experience, many of them are very sensible, you can talk reason to them, okay? And you will discover that actually pain is what defines their existence, okay? The whole chat will be about the fact that they acknowledge, some of them have stopped smoking and have stopped drinking, but pain is an ongoing thing. There have been some publications about the fact that after 10 years, what they call the pancreatic paradox, due to the complete exhaustion of all exocrine and endocrine cells, they might start to complain of less pain, but none of my patients has reached that stage yet, I have to admit, even though I've inherited them from a consultant who was there, and they have been with him for about 10 years. You get to know them quite well. Many of them are very sensible, trying to hold down jobs, and I'll come to that in a second. But it's an ongoing chase of opioid dependence, opioid tolerance, which is much more important, and the fact that they cannot get rid of that because of the ongoing pain. And how they program their life and adjust their schedule and plan and pace their activities just revolves around when the pain kicks in and the patterns that they're trying to out-cheat it. Obviously, there are the cause and the risk factors. Some of them you're very familiar with, the notorious ones such as gallstones, alcohol being the major offender in the West, and smoking. You get the less common ones such as cystic fibrosis and pancreatic trauma, autoimmune, hyperlipidemia, hyperuricemia. Speaking of pancreatic trauma, it's one of those things that you don't see very frequently, but I am aware, where I was training, of a surgeon who actually was playing cricket and got hit by a cricket ball in his abdomen and eventually died of pancreatitis. His wife is an anesthetist. Right. So for the risk stratification, they've come with this Tiger O risk stratification with toxic, metabolic, idiopathic. So T is the toxic, I is the idiopathic causes, G the genetic predisposition, which seems to be an emerging thing with everything. Now autoimmune factors, and then you've got all of them converging on the theories which will lead to chronic pancreatitis. As I mentioned, now we've got this referral system which will allow the GPs to refer on a specific email address to the hospital patients with pancreatitis. But how are they going to identify which patients we're going to receive? I get very, very frequently patients who think that they've got pancreatitis just because once upon a time an SHO passing by saw them, they had abdominal pain, oh, she's got pancreatitis, and that's it, it's stuck to her mind. But there is no evidence whatsoever that she has pancreatitis. So we're very strict and stringent on these criteria. In 1963, there was the Marseille-Rome classification of pancreatitis, which divided it into acute, chronic obstructive, chronic calcific, and chronic inflammatory. And then there was a repetition of that in 1984 and 1988. We rely more on the Cambridge classification, well, in the UK. Even if that's not a good classification, we'll still rely on it, okay? So this Cambridge classification, and we rely on this more than anything, so we must have radiologic evidence or ERCP evidence of pancreatitis with abnormal ducts and enlarged ducts and one or more cavities. So we will not just take anybody who has had an episode of acute pancreatitis, even with raised enzymes. They have to have had evidence of pancreatitis with imaging or with endoscopy. Now, this has been superseded by the Rosenblatt new endoscopic ultrasonographic classification, which will classify them into 4 stages, being healthy, possible, pancreatitis, more likely or higher possibility, or consistent with pancreatitis. But we still rely on something that has imaging modality to classify them as pancreatitis. Now, as disturbing and chronic and debilitating as its pain is, we're still discovering more and more why they get chronic pain. I think the problem, and I think that applies to all of pain management, is that we're moving from mechanically explained pain phenomena into more of neuromodulatory pain mechanisms with the autoimmune system involved. So, for example, and you'll find all of these in the theories that we've got there. So, for example, the stone and duct obstruction theory, you get a stone and duct obstructing the pancreas, you get spillage of enzymes, you get, and that's mostly for alcohol, which predisposes to stone formation and obstruction, spillage, and inflammation. And this is more of a chronic pattern. And obviously, necrosis fibrosis theory, for which you must have had an inflammatory episode before. And then with repetition, you get more pain because of necrosis and fibrosis. Toxic metabolic theory, whereby alcohol will inhibit metabolic enzymes and cause accumulation of lipid. And oxidative stress is where they speculate, Bragans and colleagues speculated that you get spillage of hepatic oxidases into the pancreatic, the bile ducts, and that's how you get the pain. I like this last chap. He's a man after my heart. They came up with the sentinel acute pancreatitis event episode. They tried apparently to compromise and please everyone. So they came with that episode that there must be a sentinel episode whereby you get an acute pancreatitis with trypsin spilling over, and that will predispose to necrosis and will predispose to periductal fibrosis, and that's how you get the pain. And in that model as well, they factor in the inflammatory mediators such as interleukin-1, interleukin-6, tumor growth factors. Now, there are a few very salient points that we need to remember. There's a poor, and that's, I think, how we moved away from mechanically explained to neuropathic plasticity, to neural plasticity type models, is the fact that you may relieve large ductal obstructions. That does not necessarily translate into the pain subsiding. And there is no correlation between the imaging and the degree of pain. Obviously, there might be other factors such as psychosocial interfering there, but we cannot say, for example, if they've got more scarring or if they've got pancreatitis, they will get more pain. We cannot establish such a link. However, we could say that progressive fibrosis generally tends to end up with more pain. Now, the most important bit, I think, that we've discovered in recent years is the neuronal damage causing peripheral sensitization and hence central sensitization, which has evolved from the seminal papers by these two gentlemen, Bockman and Buchler relying on Bockman, where they found that there is infiltration of the intrapancreatic nerves with eosinophils and inflammatory mediators. The nerves increase in diameter, there are new nerves, and they serve a smaller area, they supply a smaller area. So if you think of it, you get a higher density of nerves of more diameter. Hence, if you can link that to the recommendations that we now have for using anti-neuropathic medications, such as tricyclists and gabapentinoids, which I think we use routinely. I'm not sure about you, whether you use routinely gabapentinoids. I mean, now, if I see anyone in acute pain round, or my venerable, estimable colleague, Dr. Gopinath, if they're on tramadol, we will, before jumping to opioids, which sadly they will more likely than not end up being on. A completely different story, Sanjay, from your use of not your personal use, but the use of opioids in cancer pain. These patients, we start them on tricyclics or gabapentinoids first, based on evidence. Okay, they have got neuroplasticity, and included in that during the inflammatory stage, you've got all the gunk, all the inflammatory soup that would contribute to sensitization, the prostaglandin, the calcitonin G, CGRP, the substance P nerve growth factor. This is a very simple diagram, not busy, with everything that could possibly be involved and go wrong in that model. And obviously the connection to all of that conveys to the spinal cord is these splanchnics and the celiac plexus. Clinical features, very common. I think you can predict what I'm going to say. You've got frequent acute episodes, and then they develop acute pain with a triad of abdominal pain, endocrine pancreatic insufficiency, and eventually diabetes. The pain is typically epigastric, radiating to the back, postprandial, relieved by sitting forward, and you get nausea and vomiting. And as you're probably aware, it's this postprandial problem that makes many of them quite slim, as they are reluctant to eat because of the pain. This is a prototypical profile. I'm talking to you about This is what's written in the literature, and this is what I see in my clinic. Many of them have had a history of heavy drinking, and in heavy drinking we're talking industrial quantities, bleach quantities, heavy smoking, multiple episodes of admissions, troubled, psychosocial burden, quite significant. Having said that, none of my patients that I've come across, although that's written in the literature, seem to suffer with significant social ostracism or exclusion. I have not seen somebody who's lost a wife or a marriage or anything because of that, unlike, for example, back pain, which does happen. There's an element of depression, anxiety with many of them, poor sleep, and many of them are on opioid, favorite opioid. Interestingly, once I got a patient in clinic, I hadn't seen him before. He was on my previous colleagues' books, and I inherited him just by virtue of he. I'd never seen him before, never seen him after. He walked in, really deep antipathy to shower, you could tell, okay? And it wasn't himself who had a favorite opioid, it was his friend. He came and asked me, could you write us, that Oromorph is amazing. So I looked at them for a minute, and just and many of them, by the time they reach the pain clinic, have been started in everything. Some of it is quite welcome, as I'll come. Some of it is the medical management side of things, such as Creon, the pancreatic enzymes. So for management, you've got more than one thing, and I think this is the advantage of having an MDT, is that it gets everybody in the same clinic. So we've got a surgeon, we've got the pain management, who is myself, you've got someone who could do decompression. Normally, we liaised with the GIT, the gastroenterologist, who could do some procedures endoscopically. Radiology are always involved. Medical management as well via the gastroenterology, and general is advice. So as I say, in our MDT, we've got a smoking cessation, we've got an alcohol liaison nurse, we've got a psychologist, luckily recently, we've got a nutritionist who sits with them, and you've got the pain physician and the surgeon. And we've got a diagnosis, which is extremely important. We know that they've got pancreatitis. It's proven. In the beginning, obviously, lifestyle changes. We advise them to stop smoking, stop drinking, and the dietitian gives them advice, because, as I say, many of them are really underweight because they are reluctant to eat because of the pain. And if possible, if you can get them into support groups, which is something I think eventually with this MDT, as they're all coming for the same purpose, we could establish workshops to teach them about pain. Medical therapy, most important, many of them will be on pancreatic enzymes. They all come on Creon. Okay, well, invariably all of them are on proton pump inhibitors, occasionally octreotide, and obviously if they are diabetic, if you're at that stage, you'll find many of them on insulin. Endoscopic, we'll not go into this in details, but occasionally you can do endoscopy, and the most common thing is that they'll do stents or sphincterotomies or occasionally drain cysts. Surgery, most notorious is the Whipples, okay? And there are that many procedures, I shall not delve into them. Pain management, as useful as paracetamol is, these patients arrive in our clinic. You see paracetamol, tramadol as M&Ms, it's chocolates. They've been on it, they've maxed and overdosing. None of them, I have not seen somebody come to me at the stage of prescribing him a low dose of, say, codeine or cocodamol and selling it to him and saying, you'll be great, just try it, and seeing his back. They all are on opioids. Quite frequently, their GPs have started them on strong opioids. You will try to prescribe them antidepressants, particularly the tricyclics to start with, amitriptyline, nortriptyline, but you will start them on gabapentinoids as well. They invariably end up on pregabalin or gabapentin unless there is a reason. Nowadays, what I'm trying to do is perhaps, if they are very resistant to tramadol, is try to escalate and put them on tapentadol. But to be perfectly honest, by the time they reach the pain clinic, and this is why this pancreatic MDT is useful, they have been established on strong opioids. Now, many of them are young people. They're not cancer patients. It's a completely different ballgame. And I think we, as consultants, are at the era of inheriting the legacy of Dr. Portnoy, who in 1988 came up with that case series of 38 cases, which I believe in Egypt and possibly in many hospitals in India, you can collect 38 patient series walking down the corridor. there are that many people, but we are at the inheriting era. So in that pain clinic, myself and my colleagues, we have 500 milligram BD of zoomorph with a gram per day of oromorph, and that's just keeps on going. So if you get someone who's saying, I've got 120 BD of zoomorph, that's actually good. That's not a lot. Yeah? And actually weaning them off becomes a nightmare, and much of the work that you do, unless you do a block, will be about opioid rotation from one to the other. And then you get fed up with them, and they complain against you, and that's sort of the life. So pain interventions are very attractive, and that's why possibly I do that, as I was speaking with my colleague, and I dare say my friend by now, Dr. Sanjay there, is why I like doing these Plancknick blocks, because they keep their opioid requirements down. If not wean them off, at least it keeps them at bay. Or obviously for cancer, I do celiac plexus block. It's a completely different ball game. For chronic pancreatitis, if it's myofascial, I'll do trigger points or rectus sheath blocks or tap blocks, less likely. But quite frequently, we'll do splanchnic nerve blocks, RF. So splanchnic nerves, thermoablation. And this seems to be, I think the reason why I'm doing this clinic more than anything is because this is my unique selling point, because by the time I see them, I could juggle some painkillers, I could prescribe this and prescribe that, rotate from one opioid to the other, but I think the main thing that makes a difference is this block. Now, there's much research going on, and I'm not sure how feasible that is, but you have to be an essential. Caporal, whom Dr. Mohan, he's not here now, just mentioned, has published a paper about neuromodulation for pancreatitis pain. And Ted in Guy's and St. Thomas's has published as well about splanchnic nerve neuromodulation rather than simply spinal cord neuromodulation for pancreatic and abdominal visceral pain, which may be a way forward. And as Prof. Agrawal has mentioned, there is room as well for gene therapy now that we've established that genetics has a role to play. And that really rounds up what we do as a pancreatic MDT. We do not do neuromodulation because we don't have it in our center, and I think predominantly in the UK, it's more of still at the stage of trialing. I think Barani has recently published something about spinal cord neuromodulation, new technique for abdominal pain, but I wouldn't say that it's something that's widespread. Is the cost, because the evidence, there is a hierarchy of evidence and recommendations. So for failed back surgery syndrome, yes, for certain types of pain, you can get the sum of money because it's quite expensive. To stick £17,000 into someone, you have to have a strong justification. I'm sure, as I was mentioning to you, Ted in Guy's and Thomas, he says I'm an electrician. That's all that he does. He just sticks stimulators. But I think in the future, we might be doing more of that. But meanwhile, to be perfectly honest, I get very good results. It's one of the few things that I'm happy with is the splanchnic radiofrequency. Oh no! I'm wed to these people. I'm stuck with them. I've inherited them from my colleague, and I'm probably going to retire we were going to retire either from life or from my work, both of us. So they will carry on, but it keeps them at bay. It prevents. Let's put it this way: of the cohort that I keep repeating the block on, there's only one who's been admitted to hospital, and he's got panic attacks and personality disorder, so there are other issues about that, which is a very interesting story, because I know him, I know them, I almost know all of them by name, but now in the UK, the newest trend is that now pain clinicians are becoming dumps. I mean, we traditionally have been dumps for surgeons, now becoming dump for psychiatrists. Nothing's wrong with you. You've got schizophrenia, but it's not. Go to the pain clinicians. Okay, so I received once a phone call about this chap telling me, I need my patient. Well, what do you mean by which patient? Well, the patient tried to commit suicide and he's in hospital and waiting to be discharged, waiting for you, waiting for me. Why am I involved in this? How did I get involved in this? Apparently somebody just threw my name, and this is enough, and suddenly it's your. I don't admit nor discharge. How is it that you? So yes, but generally, with many of them are having got, apart from anxiety and depression related to pain, which seems to fluctuate with pain relief, they're not admitted to hospitals. Well, I think many of them would try to catch them twice a year, pushing it to 8. Yes, some of them get more. I have a gentleman who's had multiple surgeries, and the reason why I remember him very well is that it lasts for 1 or 2 years. And obviously the technical bits about doing the block, he had a gastrogenostomy and had a bag, and he had a stent, and you could see the stent in the. So I remember him quite well, but it lasts for more than a year, but no less than 6 months. Majority of them get it twice a year.
Yeah, Dr. Kamal, what drug you are using? Alcohol? Because
No. I do Splanchnic RFs, radio frequency. I burn.
Okay.
I use alcohol only for ciliary plexus block.
Yes. Thank you.
Okay. I put normally 20 to 25 mils each side. The papers vary between 50% to 100% alcohol. Dr. T, whom I've learned from, used to use 100%. Where I was training, they used to use 50%. I'm not as courageous as he is. I put about 80% alcohol. Please do.
One is, you talk about the enzyme supplementation. Is it so because by supplementing those enzymes, you are inhibiting the release of cholecystokinin, which is released?
It is because the cholecystokinin inducing enzyme will continue to stimulate trypsin, which is in short supply. So you give octreotide or enzymes to just suppress that and give them a bit of relief, and it actually quite works. But what I've learned from one of the gastroenterologists is that quite frequently the doses that are used that you will see the patient on are very small, 10,000, 15,000. He said anything above 65,000, give them more. The ESWL. Yeah.
How far is it quite successful?
This is very interesting. If it relieves the obstruction, it may be helpful, okay? But the problem, and this is where the neuroplasticity model comes in, so they started wondering, is it the plumbing or the wiring? Because they've relieved the obstruction, but some of the patients are still in pain. Interestingly, you get some patients who've had Whipples and still experience the same amount of the pain. I think, as I said, unfortunately I'm not that bright. That's why I waited for Prof. Agrawal to explain to me the gene therapy, because these things I just glide over. I think we're moving more and more now from trying to explain things mechanically into actually neurobiologically.
And my last comment is, when you talked about antioxidants, just the last one, antioxidants, because 2 trials, I'm talking of IBS, where one of them got published from India only, that's institutional trial, it failed to show any efficacy of antioxidants in IBS. So is there any evidence for pancreatitis, the antioxidants?
No, I agree with you, but their argument is very pragmatic. They said, what will you lose? I agree with you fully, but it's just these patients are at the end of their tether. People are frustrated, so they say, we'll give them multivitamins. All of them are in vitamin B12. They have stopped smoking, drinking, but they're in vitamin B12. There is conflicting and poor evidence to antioxidants, but they just give them everything. So they give them PPIs to suppress gastric. They try everything with them, because at this stage, their argument is it's not going to harm and may be beneficial.
Thank you, Dr. Kamal,
Thank
for
you very
very
much.
nice presentation and very good discussion about the topic.
Thank you very much.
This is Info Media Prime Slot Network, and you're watching Prime. Your voice, your channel.